MTCT programme. So, as this audience will know, WHO developed guidelines for PMTCT in developing countries in 2010 for options A and B, and then updated these in 2013 for option B plus and option B. And at the time that the guidelines were introduced, WHO emphasised the importance of getting data to assess population-level effectiveness of these interventions. So in Zimbabwe, the prevalence of HIV among pregnant women in 2012 was 16%, and that resulted in a transmission of around 9,000 infections to infants during 2013. Option A was rolled out very quickly across Zimbabwe between August and December 2011 to almost all of the health facilities across the country. The initial plan had been to evaluate option A using a survey in 2012 and then again in 2015. But following the WHO guideline revision in 2013, option B plus was started in 2013, and so we brought our end line for option A survey forward. So in terms of the impact evaluation, we did 2 cross-sectional surveys in 5 of Zimbabwe's 10 provinces. We used a pre-post design with facility catchment area as the unit of analysis. The baseline survey was conducted in 2012, and as I've mentioned, the end line was conducted in 2014. So there were 2 stages to the sampling. In stage 1, we selected 157 facilities from over 600 facilities in those 5 provinces, and at each facility we administered a facility questionnaire to determine the timing of option A rollout at that facility. And then in the second stage, we identified all eligible infants living in the catchment area of those facilities, and selected a predetermined sampling fraction of eligible mother-infant pairs and invited them to take part in the survey. In 2012, we recruited just over 9,000 mother-infant pairs, and in 2014, 10,646. Mother-infant pair participants, the mother or caregiver completed a questionnaire. A blood sample was taken from living infants and mothers, and verbal autopsies were performed of deceased mothers and deceased infants. And the main outcome for this stage of the study was HIV-free infant survival at 9 to 18 months and mother-to-child transmission at 9 to 18 months. So eligible mother-infant pairs, eligible mothers were over 16 years old, 16 years old or over, and were biological mothers of infants who were either alive or deceased, living in the catchment areas of the facilities that were included. And they were mothers of infants who were 9 to 18 months old. So we were trying to get some late transmissions following delivery, although breastfeeding in Zimbabwe goes up to 18 months, so we were aware that some infants would still be being breastfed. And then we conducted an impact analysis which was limited to those catchment areas, so 113 of 157, which were unexposed to option A at baseline according to facility records. We'd hoped that would be all 157, but Ministry of Health managed to roll out option A so quickly that we were unable to keep up with them. HIV-free infant survival is the proportion of infants born to HIV-infected mothers who were alive and HIV uninfected at 9 to 18 months, whereas mother-to-child transmission is the proportion of infants born to HIV-infected mothers who were HIV-infected at 9 to 18 months. And we estimated the HIV-free survival and MTCT rate in each catchment area and compared that between 2012 and 2014 estimates. So here are the data from the 2 surveys. I've already given you the number of participants. Our overall response rate was very high in both surveys, likely because we were offering EID for the infants. The mother-infants, some of the mother-infant pairs, the infants were deceased, as you can see on this slide. And we had over 8,500 viable blood samples in the 2012 survey and just over 9,800 in the 2014 survey. So if we look at the individual level analyses, first of all, you can see that the the HIV-free survival rate has increased between 2012 and 2014. So from just under 91% to just over 93%. And this trend, although encouraging, was not statistically significant. If we look at the individual level analyses for mother-to-child transmission, again you can see that the mother-to-child transmission rate has fallen from 8.8% down to 6.7%. But again, this difference was not statistically significant. When we restrict the analysis to those 113 catchment areas where option A was implemented after the baseline survey was conducted, you can see that there's a statistically significant increase, 5.5% increase in HIV infant-free survival, and a 5.2 percentage point decrease in mother-to-child transmission rates since the rollout of option A. And we interpret these findings as due mostly to option A. There's a poster being shown tomorrow, which I think is now also going to be an oral presentation, which looks at the geospatial mapping of mother-to-child transmission rates and HIV-infected infants. And really just what I wanted to show you here was in the left-hand map, you can see the geospatial mapping for 2012, and the large red spots are the facilities with high rates of mother-to-child transmission and also large numbers of HIV-infected infants. And as you can see, the map in 2014 has fewer large red spots and much greater number of small white spots, which are those health facilities where no transmissions occurred. So of course there are limitations to this approach. We're using an implementation science approach. Our data were cross-sectional, and because we were only able to survey 5 of the 10 provinces and not representative of all regions in Zimbabwe. However, we did include 3 of the 4 largest cities and areas in both the north and the south of the country with different HIV prevalence rates. I've already mentioned that quite a large proportion of mothers were still breastfeeding at the time of the survey, and so onward, later transmissions could still occur. And of course, infant deaths may have been underreported. So this is a quasi-experimental design, and we have been able to do analyses looking at differences according to rates of implementation within facilities. So in the conclusion, Zimbabwe is approaching virtual elimination of mother-to-child transmission. These community-based estimates show substantial and statistically significant increases in HIV-free survival and decreases in mother-to-child transmission after option A implementation. This is really encouraging, and obviously with the implementation of option B+, we hope Zimbabwe rapidly moves towards elimination of mother-to-child transmission. The 2014 survey will serve as a baseline for option B+, evaluation of option B+, and we're planning to do a repeat survey using the same design in the same catchment areas in 2017. Importantly, our community-based surveys included many women who didn't access health services which is a limitation of facility-based surveys. We've got other data being presented at this meeting relating to the study, including a poster which is looking at uptake across the cascade, and as I mentioned, the geospatial mapping analysis, which is being presented tomorrow. I'd like to thank the Zimbabwe Ministry of Health and Child Care co-investigators, EGPAF Zimbabwe, who coordinate the implementation of PMTCT across Zimbabwe with the Ministry of Health and Ofid Trust, and the funders for the study, and of course, not least, the study participants. Thank you.